Good morning, everyone, and welcome to this year's first Journal Club for 2019. Thank you for everyone joining, both in here at NCAS and online. Feel free to ask questions online. We'll ask those at the end of the session. And again, get questions into the session here if you can, and we'll answer those. Our first talk for today is by Dr. Helen Crabb, who is a postdoc here at the National Centre for Antimicrobial Stewardship, who works in our animal stream. And her talk today is discussing antimicrobial stewardship in food production animals. Thank you, Helen.
Thank you. Okay, so it's not so much a journal club as in a quick run through of 1,000 things I've done this year, for those of you who don't think I've been doing anything. A lot of the stuff that I'm going to talk about is abbreviated, and some of it's not confidential, but I can't share the confidential stuff. So you'll go, that doesn't make any sense, and I'll explain why. Okay, so I'm a food production animal veterinarian, and you eat my patients, all right? And so in my career, what I do is I make sure that food is safe for human consumption. And so I have quite a different role from a companion animal veterinarian or a sport animal veterinarian, in that I make sure that what you're eating is safe for human consumption. Here's some of my patients. I currently work with poultry, but I've worked with dairy, sheep and beef, and pigs, and currently I'm a poultry vet. And the reason I like intensive livestock, for those of you that don't know, is they come with data, and I'm an epidemiologist. So animals that come with data you can do something with. The rest of the animals you can just hope you can do something with. So as all epidemiologists will tell you, if there is no data, then nothing happens. We don't know anything. The biggest problem that I think with regards to antimicrobial stewardship, both amongst veterinarians and the medical profession and the general public, is basically ignorance and misinformation. My whole career, we talk about how do we communicate with the public about intensive livestock production systems, how do we get people to understand what farming is, how do we get them to understand what the right way to treat animals is, and we've been talking about that for a long, long time. And nothing has changed, I might add. We're still talking about it, and we still haven't made any progress on that. There's a lack of awareness of what appropriate animal production or what normal is for animal production systems. And when people talk about what vets do, basically even vets don't know what vets who work in food production animal medicine do. So we have ignorance on all fronts. We have classes in veterinary science, as I'm sure we have in medical professions, in that if you're a food production animal vet, then if you're a cattle vet, you're up here. If you're a sheep vet, you might be here. If you're a pig or poultry vet, then you're definitely way down the bottom, because people don't like the way animals are raised intensively, even though they don't work in our industry and they have no idea what we do. So the other thing that we have to battle is that we have an absence of information. And because the assumption is that there's an absence of information, it means that we're therefore lying and we've got stuff to hide. That isn't actually the case. Sometimes it might be the case, but that occurs everywhere. But the reality is that a lot of the information that we have is so commercially sensitive that people are afraid to share it. And they're afraid to share it because of the consequences of sharing. Because then, of course, once you've got some real hard data out there, then people can judge you, and people can make judgments about what's right or what's wrong based on their worldview. And just because we don't have any information doesn't mean that there is nothing to do. And one of the things that we're currently battling is the fact that people are telling us that they're doing everything right, but there's no way of actually assessing that because there is no data. So it's a catch, certainly a big catch-22. So I thought, in the aim of trying to educate you about what I do, I'll give you a quick one-on-one 101 on what a chicken farm and poultry production looks like. So if any of you like Google Maps or Google World, you can go online and have a look for some properties that look like this. They're super easy to spot because Australia is full of a lot of nothing, and then you'll spot something and it will probably look like this, and it will look like 4 or 5 sheds or 8 sheds, generally in configurations of 4 or more in multiple units. And if it looks like this, nice and well organised, then it's probably a broiler farm. If it's a piggery, it won't look like this. It'll be a little bit more higgledy-piggledy, and it'll be much more organic looking. And so we rear birds in bulk, for want of a better term, and it's very organised and very structured. The poultry industry has been growing exponentially for the last 40 odd years, and it's new. All the operations are increasingly new, and it's growing, literally growing exponentially. So from the outside, this is what we have: a bunch of sheds with silos, lots of fans on the side to cool the chickens down. And we deliver our birds at day old. They get raised in a hatchery, they get delivered in trucks. They may go 100, 200, 500 kilometres from the hatchery to the farm that they're going to be reared on, and then they get placed in a shed at day of age. So these birds have just literally been placed, and they're in that shed there that I just showed you. And this is what they look like about 2 minutes after they've been placed in the ground, and they start walking around and looking for feed and water. 10 days later, they're up and eating, and you're thinking they don't look much different. And here they are another week later, they're getting bigger. So we have the shed set up so that people, the negative Nancy's in the room, will all say that so that we don't want them to move around and we overcrowd them. But what we do is we have the shed set up so that we have water and feeders very close by so that they don't have to move, but they will willingly move backwards and forwards within the shed. So if you walked into the shed, they'd all leave and head off to the other end of the shed. So what we're doing is trying to make them as efficient as possible in terms of their growth and production. So this is 28 days of age, and you can see that they've quite substantially grown to fill the space in which they have been placed. And at market age, and for those of you that don't know, it takes 32 days to raise a broiler for meat production. That's it, that's the lifespan of a broiler. So those of you that enjoy eating chicken meat, they are 32 days of age at 1.6 kilos, which is what you are buying at the supermarket as a rotisserie chicken. So that's our market, and that's a majority of a fresh meat market. So you can see that these birds have reached their mature body size by about this 35-day age, which means that I have very limited opportunity in which I was going to treat an animal if I was going to treat it for a disease. As you can imagine, 5 weeks isn't much of a choice. I've got to make a diagnosis. I've got to then work out what I'm going to treat them with, if I can treat them, and then I've got to consider things like withholding periods, because obviously it's got to be safe for human consumption. So there's about half a dozen products that I have available to me if I'm going to treat with antibiotics. That's pretty much the only choice of drug I have to use in the broiler industry. There aren't any other drugs. It's antibiotics or nothing. So I can vaccinate them to prevent disease. I do that right at day old. And then my only other choice of treatment as such would be an antibiotic. All the rest of the diseases I can do nothing for, other than watch them die. So I deal with population medicine. My flocks range in size from 20,000 to 100,000 birds. And so I'm not dealing with individuals. I'm dealing with flocks of animals. And what I want to know is what is normal. So on every farm, in every shed, every farm manager, we have all these things that we need to understand about what's normal for the farm, for the flock or herd, what's normal for that particular breed. So some layer birds do one thing, while some layer birds do a different thing. They all have their own little quirks, and we need to know then what's correct for this breed, for their age, weight, morbidity. Is it normal in their levels of production? So all those things go into consideration when I'm trying to make a diagnosis or work out what's going on in that flock. Unlike, sorry, that was supposed to come with a warning before I showed you this picture. For those of you offended, luckily for me, they die, or maybe not so luckily for them. And so I make a diagnosis in the field because in the broiler industry, they die. And so because there's 60,000 of them, even though I might only lose 10, I still have 10. And so I have 10 that I can open up every day so I can work out what's going on. So I can do the pathology or gross pathology in the field. And luckily also, if you get to see them early, most of the bacterial diseases that I might be able to treat are quite easily distinguishable in the field, as long as they're caught early. Once they're caught late, then anything's a good guess. But it is one advantage that I, as a production vet, and poultry particularly, have. At this age, so these are like 2-week-old chicks, at 2 weeks of age, there's very few diseases that are going to be, I can't treat them now, it's too late, they should have called me a week earlier, so I can't put any drugs in because they're going to be killed in 2 weeks' time. So there's no drugs I can treat. These birds have E. coli. There's no drug I can use for E. coli at that age anyway that will do anything for them. So they rang me at the wrong time, but I also can diagnose that based on what their gross pathology looks like. I don't need a lab. I don't need any micro. And I don't need culture and sensitivity because I'm not going to treat anyway. So the decision's already made before I arrived. What age are they? Can I treat them? Is there enough time in that window that I can actually put a drug in there? No. So I already know that I'm not going to give them an antibiotic before I get on the farm. What I'm trying to do, though, is make sure there's nothing else going on that's going to affect the other 7 sheds on that farm, and that it's not infectious disease like avian influenza or something that's of much more economic consideration for me. So what do we do? 99.9% of my time is about disease prevention. So I do all-in, all-out production, which is one flock of one age in at a time. We spend all our time working on cleaning and disinfection. As you can imagine, it's not a hospital, it's a farm, dirt floors, full of dust, full of gross organic material. And so cleaning and disinfection is very difficult. Obviously, it promotes certain types of antimicrobial resistance. And so getting it right is very important. We worry about the population. We worry about improving infrastructure. We do things on biosecurity, and I say strict, it's a relative thing. When I go to Dr. Dax and I see the doctors in their scrubs or the nurses in their scrubs or heading over for coffee, I can't do that. I would never leave the farm wearing the clothes that I would go onto the shed and onto my farm with. I don't get in my car in the clothes that I've been wearing in the sheds. I wear overalls and protective gear on site, site-specific equipment. It stays on site. I wouldn't even think about going to the next shed without a different pair of overalls or coveralls or boots on. Our primary method of disease treatment is prevention, and we do vaccination. And the one thing I was going to put up was a vaccination schedule. My breeders get vaccinated, 12 different vaccines. They get vaccinated 6 times with multiple vaccines through their life in the first 16 weeks of life before they come into lay. That's how we prevent disease. The most inefficient vaccines are all our bacterial ones, and they are the ones that we struggle the most with, and hopefully Glenn's team will end up making the rest of those vaccines good for us. And obviously water quality is highly important. But we work in agriculture, and no one would say that if you're a food business or a shopkeeper, a supermarket or a hospital, that you're not going to make money. You have to make money to pay your staff. You have to make money to run a business. If you're not making money when you run a business, then it's called a hobby. And so unfortunately, agriculture is a business. And so people that work in agriculture generally love animals, but they also have to pay to do that, right? It doesn't come for free. We don't have a government that's paying Medicare for the cost of looking after our animals, and you guys pay for that. The more it costs, the more food costs. So agriculture is a business. Disease affects productivity, it increases cost, but prevention also increases cost. And of course, diseases are unpredictable. So we can prevent what we can, but sometimes things happen that are outside of our best abilities. And it's really important to know that what we're trying to do is actually make money, as economic as that sounds, but that is quite the reality. So what are our challenges? Our challenges are that internationally we have a focus on absolute reduction in quantity of antimicrobials used. There is a focus on food production animals, and we in Australia have a very restricted choice of antimicrobials for use in agriculture, particularly. Now, we like to think that we already have a relatively low use in Australia. And of course, because of that, we actually have very little incentive for change. We already think we're at the top of the world because we're already doing really well. Our surveillance is showing quite clearly that from an antimicrobial resistance point of view, transference to humans, that animals aren't actually the primary driver for that in Australia. And so from a veterinary point of view and from an agricultural point of view, there is quite a large swelling of people that believe there's no incentive for change. However, we have quite a huge market push from both the consumer and from the medical fraternity for banning of antimicrobials and for marketing of antimicrobial-free product, whatever that means. But our biggest issue really at the end of the day is funding. There's no advantage, there's no market advantage in Australia to being antimicrobial free. There's no one that's going to randomly fund this. So making change in the sector, in the agricultural sector, is quite fraught with some real challenges to that. And so the other thing that we need to do is we need to stop othering. And for those of you that don't know what othering is, that's that. That's where we blame someone else for our problems. In agriculture, in veterinary medicine, we are to blame for any antimicrobial resistance that occurs in our animals, just as the medical fraternity and those who prescribe in various sectors are responsible for antimicrobial resistance in their populations. Blaming other groups for that problem is absolutely not helpful, and hopefully why we're doing a One Health approach. So one of the things that I talked about at the forum was about comparing human and veterinary medicine. So in veterinary medicine, we talk about population corrected units, where we compare our population use by the weight of the animals at their average age of treatment. We can then go to what's called defined daily doses of veterinary medicines, where we're defining our dose per unit of weight, or we can do defined course doses. So they're slightly different. We talk about milligrams per kilogram by unit, whereas obviously in human medicine, you're talking, often frequently talk in grams per day. So we talk about milligrams per kilogram. And the reason we have such a difficult issue with this is because this is our population. They don't weigh 70 kilos. They're ruminants, monogastrics, any kind of other animal that fits into that, warm-blooded, cold-blooded. And so they're all different. So trying to compare across our populations and then compare to a human population is particularly difficult. And it's fraught with all kinds of assumptions. It's bad enough when you're just assuming the difference between an adult and a child. Imagine we're not even having a conversation about small animals, as in baby animals and adult animals. That's like a whole nother level of pain. We still can't even agree between ducks and chickens. And you'd think, well, they're just the same, right? Not so much. So here's some information to show you the comparison between defined daily doses in milligrams per kilogram of the same drugs. For lincomycin, amoxicillin, and trimethoprim sulfur, the relative difference between the amount of dose that they require parenterally, and we can't even give most of these in terms of pigs and chickens parenterally, we give them orally, so the bioavailability is much, much lower than if I was giving an injection. I love listening to your talks when you talk about oral IV switch, and I'm like, oh, to be able to do IV, wouldn't that be amazing? And just hope that I could get the drugs into their vein. But that's just not a reality. But you can see the difference in dose just between a cow and a chicken. So when we have these really unfortunate conversations where we talk about volume of antimicrobial sold, and people go, wow, you know, all those cows, they're getting all those drugs. They also weigh 500 kilos. So of course they're getting all those drugs, because they weigh 500 kilos. Just imagine if your whole population was 500 kilos, then the human amount of antibiotic that you're using would be a lot higher. So it's just, you know, it's comparing apples and apples, right? So here's some numbers. This is from Laura's work over on the right, and Kirsten's and everyone's work, about how many doses of antimicrobials that animals and humans are exposed to. So the stuff on the left is what I know I've prescribed in the populations that I'm responsible for. So I've not treated any broilers in the last 5 years with any antimicrobials. So no prophylaxis, no metaphylaxis, no treatment, but I have treated one flock with antibiotics in a layer flock. And so in effect, you can see that the actual annual dose is much, much lower. And that would be very true for most poultry veterinarians. We don't see disease that frequently, and 90% of our time is spent on prevention. So one of the biggest problems we have right now is that in 2005, so I can't remember what year they published this, 2011, 12, it's getting old now. The graph on the left, Australia's really loves this graph. We see it all the time to show how great we're doing in terms of antimicrobial use per unit of livestock. So that's where we were. That data is based on the 2005-2010 antimicrobial sales data. Now in 2018, you can see I've just randomly selected some countries, the highest and the lowest, and you can see that everyone's catching up because they're actually doing something. So the UK has reduced their antimicrobial use per animal and are actually measuring it quite substantially. And now they're sitting pretty much alongside us in terms of antimicrobial use. So there are some worrying trends there in terms of what are we actually doing and why, where are we going? What does that actually look like? And this is based on sales data. This is not based on actual use data. So I pulled out some, I'm sorry that's truncated itself, but I pulled out the data to compare using that 2005-2010 data. Well, what does our antimicrobial use look like in comparison to the rest of the world? And where do we sit? We're over here. I don't have a pointer in the green down here, and you can see compared to the rest of the world, our use of certain products is generally lower. But you can see that the third one in is macrolides, and that we are actually higher in macrolide use compared to some of the other countries other than, some of the other countries.
And is that all species in?
That's all species in. So it's just gross from our.
And what's the species?
So that's milligrams per kilogram, basically. So it's population corrected. So it's corrected across all of the livestock for the average estimated age that you would treat. So I've averaged it so that it's comparable with the European, so using European calculations, so it's directly comparable. Before it wasn't. So I've taken it from what we know from our sales information. What we don't know, because it's based on sales, is what the actual use is in terms of the actual production animals and which sectors are the ones that are using the drugs. So you can see over on the right, we don't have any of those drugs for use in food production animals. So they don't rank, so that's fluoroquinolones and those drugs. We have the major 4 classes though. So we've done a survey of poultry veterinarians to find out what drugs they're actually using and when. And you can see that we have quite a range of drugs that are registered for use in poultry, but it turns out that only 3 of them or 4 of them are actually being used. Why? Because the rest of them don't work. They're not available in forms that are able to be used easily. So we tend to put our antibiotics in drinking water in poultry simply because we want to be able to treat today, treat them for 2 days and pull it out. If you order feed, then it takes a week and you have to wait for the feed to come, and then you have to feed a certain amount, and usually it's a week's worth of feed. Managing treated feed is quite difficult, and so in the layer and the broiler industry we tend to treat in water. So a lot of those products aren't available to us, or we don't tend to use them. So from the survey, this is the dosing that we have, and we're going to use that information to start formulating our prescribing guidelines. And so we have some pretty good information that we've received from the veterinarians with regards to how we're using antimicrobials in broilers and layers. But the reality is that we have 6 prescribing veterinarians that actually treat in Australia. So you can see why people might be a little bit reluctant to talk about what you're using and when and how, because there's 6 identifiable people. There's not 600 hospitals, there's 6 people that do most of the prescribing in that sector. And that one of those people would be me. So, so it makes it a very difficult conversation you have, because you can't de-identify us. We can all get together in a lift and have a secret conversation. And if we add the pig vets in there, it will just be a little bit more crowded, but it's not much more crowded, because the reality is that there's actually only a really small number of us that could prescribe into those sectors. So based on the survey, I have estimated what percentage of our antimicrobial classes are being used within each of those sectors. And I think that most of the antibiotics, and I know that most of the antibiotics are being used in the pig sector and not in the poultry sector, just based on the survey information, because we know we don't use streptogramins in pigs or poultry, and we know that the rest of the antimicrobials aren't going into cattle, so by default they have to be going into pigs. And so then, using that 2005 surveillance data, you can see that there's a huge discrepancy. If we average across all of our animal species, you would see that our amount of antibiotics used per kilo of animal is very low, because thankfully sheep don't use anything. We have a huge population of sheep, yay, go sheep. But that by default means that if the drugs are going into pigs, then how much drugs are going into pigs? We don't know. This is estimate. This is based on what I know about how we've been prescribing, or what the registration data is, and what we know from the poultry survey and from the pig prescribing guidelines, and what people are saying that they might prescribe. So this is based on what people are saying they might prescribe. It's not actually based on what they're actually doing. So this is where the drugs would appear that they might go. So we need to truth that. We don't know for sure that that's actually really what people are doing. So luckily for you, we did a really groovy survey during the forum. So I'm going to share with you lastly my results from that. So we had a panel discussion and audience participation survey at the end of the second day, wasn't it? Second day? And so these are the results of that. So what we wanted to do was we wanted to find out whether people really thought that antimicrobial resistance in animals was a problem and that we were the source of all evil. And we hoped that by having a panel discussion that we might get some feedback from those attendees and see what they thought. So we had approximately 70 people start the forum, and of those we had 62 of them actually respond to the survey. So we had a pretty good response rate to start with. Unfortunately, at the end of the forum, we'd lost half our audience. Doctors, what can I tell you? They were bored, they left. And so we had a pretty good engagement, but it was at the wrong end of the day. So here we go. Who did we lose? The demographics, they're statistically insignificant in terms of the befores and afters for the amount of years in practice. So if I do this one, oh yeah. So we had doctors, vets and others. And you can see that the doctors left and we stayed, the vets and the others. But the demographics were the same before and after in terms of how long that they had been in practice and whether they prescribed or not. So there's no statistically significant difference between that other than the fact that we lost the doctors. So either the doctors had to rush off for something else or it was super boring and they already knew the answer, so they left. So we asked 7 questions. And we wanted to know of the antimicrobial resistant infections in humans, which percentage were attributable to animals. And you can see there was a statistically significant difference before and after, which I was quite surprised. So no one else has seen these results because I literally did the analysis last night. I apologise to my colleagues. So what we saw initially was that, up to 80% of cases were considered to be caused by animals before, but then everyone came around to our way of thinking at the end, and more than 80% of them decided that less than 10% of cases were attributable to animals. But there's just still some outliers. So there's some people that really don't want to believe that animals aren't responsible in Australia. So then we wanted to know, with regards to animals as a source of antimicrobial resistance in humans, was the use of antimicrobials in food animals more important than use in companion animals? So at the start, 40% of people agreed that use in food animals was really important. By the end, 31% disagreed that it was really important. So that is statistically significant change from one to the other. So that was quite cool. So we've managed to drop at least 10% of people's opinion on that, which is good. We asked whether people should ban the use of antimicrobials in certain animal groups. Surprisingly, I was quite surprised at how many people didn't think we needed to ban antimicrobial use in animals, because that's not what you hear, that's not what the media portrays, and that's not the messaging you get. So I was surprised that 70% of people didn't think we should ban it, but obviously everyone else thinks we should ban the use in food animals, of course. But surprisingly, we did manage to change their opinion, so less than 10% of people think that we should ban the use in food animals now that they know what we actually do. And that, again, was a statistically significant change, even taking into account the change in population size. So we wanted to know also if the control of antimicrobial use in animals will control antimicrobial resistance in humans. 19% of people initially thought that they agreed that controlling use in animals would control antimicrobial resistance in humans at the start, and then 42% of people disagreed at the end. So it would seem that the panel discussion actually had some kind of influence on what people were thinking. And lastly, we asked people to rank what things we thought would be really important in terms of what they think veterinary prescribing should do. Unfortunately, that was really difficult to do in the survey, and really the only thing that changed was the relative position of banning off-label use in animals and removing the right to prescribe and dispense. So they just changed their relative importance. So it would appear that our forum was quite effective in terms of actually changing people's opinions about how they think about stuff. It would have been nice if more medicos had stayed so that we could actually see if we had influence on the peer group we wished to change their opinion of the most. And obviously this is an educated group. I was kind of disappointed that even though we really tried hard to get super controversial people in the panel together, they were just too agreeant. And so they all wanted to agree, and I was quite sad that that was not at all controversial, which I would have liked a little bit more fire. But anyway, so what else do we wish we knew? Last but not least. So basically, we know that antimicrobial use by registration is not accurate. And what we don't know is how inaccurate it actually is. The last time that antimicrobial sales data was provided in Australia or summarised was 2005-2010. It's limited to broad groups by sales volume. We can get sales data. And so it only tells us what's legally purchased, and it has to be publicly available for scrutiny. Every other country in the world now, just about, with the exception of some, China and those kinds of places, you can actually go online and you can find out what is being bought in active ingredient. The Australian government has said that they won't publish that data because it's too commercially sensitive. If you can get a PBS data, then you should be able to get the veterinary data. If we don't have that data, then we've got no way of truthing or identifying illegal importation of product. We've got no way of knowing what's being legally imported. If we identify an issue with regards to that sort of thing, then we've got no way of actually knowing that, and we're reliant on the regulatory system to actually work, and they want us to pay for everything, so it's never going to work in that case. So it doesn't tell us anything about use. It doesn't tell us anything about duration, the dose, species, or appropriateness. It's just volumes of sales data, and it doesn't tell us anything useful, as you can imagine. Here's what the sales looks like, and all I can tell you is from the value of data that the amount of antibiotic that's being sold, and the orange, which is products like the growth promotants, which are already in decline anyway, and things like streptogramins, that those values have decreased. So the question is the value representative of reduction in the actual amount of drugs sold, or is it just that it's got cheaper over time? I've got no way of knowing. But in terms of the actual number of items within each class, they're essentially flat. So the number of items in each class hasn't changed, and so they've remained constant for a long time. So you could make some educated guesses about what that might mean, but the reality is that from a usefulness in terms of appropriateness, we've just got nothing to go on unless we get some real data from people about what people are actually using and how they're prescribing them. We know we have issues with labels. When I was in at the Antimicrobial Agents in Veterinary Medicine meeting and the Salmonella meeting last year, everyone was talking about veterinary use of product. Penicillin, trimethoprim sulfur, all of the old first generation antibiotics. Labelling is a massive issue, and it's a veterinary and human issue in terms of doses are incorrect and inaccurate for appropriate dosing. And because those products are now generics, there isn't anyone that's going to fund those studies to be redone in our populations. All our population pharmacokinetic models have been done a very long time ago. Our animals have changed. The animals of 50 years ago are not the animals of today. And you laugh, but 50 years ago, it took 60 days to raise a chicken to 1.6 kilos. It takes 30 days. They are not the same animals. So those pharmacokinetics don't work. And they've not been ever done for poultry, commercial poultry. So this was talked about a lot by just about everybody that I spoke to, and everyone has the exact same issue with regards to labelling and dosing. And I'm not going to talk about that because I already talked about it. We calculated how many animals you'd need to eat if you're a meat eater to be exposed to a multi-drug resistant organism. Beef, you need to eat 379 beef meals. This is the only animal, they found one multi-drug resistant organism in the only food survey that's been done. So you're safe. You have to eat beef every day, more than a year, to even be exposed from an animal product. And if you don't cook it, well, then you've probably got more risk. But that's if you don't cook it. And chicken and pork, 0. Based on the only data that's available to us. So we need to know a whole bunch more data about this stuff. And I would argue as a veterinarian that I need more choice. I can't provide short course treatment with an appropriate drug at an appropriate dose rate because I haven't even got drugs that I can use that will allow me to do that. All the drugs of my first choice are all broad spectrum that treat multiple organisms and not the organism of my choice. And we know that if I do all those things, then I can reduce selection pressure for multi-drug resistant organisms. And finally, the one last thing that I think is really, really important that we haven't actually yet even begun to discuss in the veterinary sector, which I think has ramifications for humans, but much more ramification from a veterinary professional ethics point of view, is that with the pressure from industry on veterinarians and the pressure from animal rights groups, the food industry, fast food industry, to ban the use of antimicrobials in food production animals, as a veterinarian, my responsibility is not only to appropriately treat, but I'm also responsible for the welfare of my livestock. And I'm legally responsible for that. That's just not a whimmy thing. That's a legal responsibility under all the acts and legislation. One of the things I'm working on at the moment is cobbling together all the acts and all the bits of legislation that I'm responsible for. As a veterinarian, I have clients in multiple states. So that means that I have to obey the rules in every state that I treat in. In Victoria alone, there's 13 pieces of separate legislation that I'm responsible to just for prescribing. Rules, gazetted rules, orders, and guidelines that I'm obliged to follow. There's 13 of them. That's just in Victoria. Some of them are about immediate prescribing, but some of them are about who's a bona fide client, when I'm responsible for treatment, when I'm responsible for euthanasia, when I'm responsible for welfare under those conditions. The one thing that we're not talking about is when a client refuses to treat for a disease that is treatable. So I know that from an animal welfare point of view, that people would say that it's not acceptable to allow an increase in mortality for a disease that's treatable or preventable. Yet I have clients that tell me that they are antimicrobial free and they will not treat. Where do I stand legally or ethically in that situation where I'm faced with something I know that will respond to an antibiotic and they'll be fine and they won't suffer for 4 days? Because the alternative is that we kill them. We know that in Denmark, that when they removed the use of antibiotics for growth promotion, that they had an increase in treatment use of antimicrobials. Now that's subsided, but what I found out was that pig herds, 16% of pig herds were positive for MRSA, and now 88% of herds are positive for MRSA. And the small subtext that nobody actually noticed was that the increase in population mortality in Denmark was 0.4%. It was dismissed as not being that important. What that is, 120,000 extra dead pigs. That doesn't sound like much, and it really isn't when you've got a population of some 16 or 20 million pigs. But think about, I don't know, has anyone been to Denmark lately and seen how big that is? Where do you put 120,000 extra dead pigs in a place like Denmark? It's not like you can go out to the desert and bury them in a big hole. You have to find somewhere to deal with them. So not even if we're dealing with just an animal welfare issue. Those are the unintended consequences of removing antibiotics. We need more epidemiology. And finally, my last comment is that if we raise our animals without antimicrobials, does that mean we're raising them without care? Raising them without welfare or ethics, mine included? And in the case of some people, they see that as a reason not to get a veterinarian, because they don't need one anymore, because in food production animals, the only drugs I can use in poultry, other than vaccine, which can be bought available freely, is to prescribe antimicrobials. That's the only time you actually need a vet. And that's all I have to say. Food for thought. Does anyone have any questions?
Good question, Helen. You did a great job of talking more about the Australian situation, but when we go to conferences, what we're hearing about is Southeast Asia, China, and that situation. And what do you think your role is in maybe advocating for how to change what's going on over there? Or what's your understanding of what's going on over there? I mean, we see it from the perspective that we're delivered in conferences, but what are you hearing? And then what do you think? You know, how do you think we could perhaps lead or demonstrate how things might be able to be improved?
Sorry?
That should be a question for other people online.
Okay, that's a great question. The biggest problem that you have in Southeast Asia, as a general statement, is the level of education of veterinary services, government provided, huge, and certainly in the aid-based areas with large input from WHO, FAO, OIE. They're all focused on emerging infectious diseases or emergency animal diseases. So the global focus for them is foot and mouth disease, avian influenza. So yes, antimicrobial stewardship is increasing in importance, but we're talking about, ignoring China, third world, third tier countries where agriculture has got no value other than survival value. So the market is small. It does depend on country by country. Access to antimicrobials has no governance. So there's no governance systems in place, regardless of what we're talking about. So there's very little. And then they have no veterinary services to speak of in terms of independent veterinary advice. So those areas are all identified and all addressed. But even in Australia, if you want to talk about antimicrobial stewardship, our focus is currently on what resistant organisms are being transferred from animals to humans. Now, the reality is that probably very few. But what about the the organisms of importance to animals that have multi-drug resistance. There's plenty of those, but we have completely skipped that conversation. And we're not even talking about it. They're just worried about what you might catch from my animals based on my use. And so we're overly focused on multi-drug resistant organisms of importance to humans. And we're not even talking about multi-drug resistant organisms of importance to animals that are untreatable. I saw a whole bunch of slides at ABAMS just recently talking about how amazing it was, and look, the surveillance is really great, and everyone was completely ignoring the fact there was multi-drug resistance to all of the primary pathogens of importance to animals that aren't important to humans at all. Mycoplasma. Can't treat them. There are no drugs that work, yet we're not talking about that. So we have, because we're so focused on our role in terms of food and human transference, we're completely ignoring the fact that that a lot of our drugs are not available for us to use because they just don't work anymore, because that's all we have. What can we offer in terms of Southeast Asia? The cynic in me would say we need the FAO and the OIE and the WHO to step back and let market forces work so we could actually get our foot in the ground. But because it's all aid focused and it's all avian influenza and foot and mouth disease focused, I go to meetings and you talk to vets and they're like going, oh, there's diseases other than avian influenza, because that's what the focus is always on. It's always on about emerging infectious diseases. And so talking about bacterial diseases, talking about food safety, there's programs in there, but the infrastructure has to be set up. And so, yes, it's completely different in Southeast Asia, and I understand the difference, but those conversations are at just such a different level than they are in the medical profession. I don't have any solutions for that, because I don't even know where you'd start. Glenn, do you have any ideas?
I think there are, well, the major thing we can do is probably get more vaccination in those industries in Southeast Asia. I think one of the difficulties is that a lot of the companies that operate in those countries are selling both the drugs and the vaccines. Yeah. Yeah. So they're often significantly limited in their advice about which product to use. So that's one of the.
And we don't have a lot of epidemiology. I, as a data person, one of the problems we have is that we can't combat some of the the conversations with some real data. And then when you do have it, getting it published is really difficult because we get, oh, you're from Australia, it's not relevant. And then, because it's not relevant to the rest of the world apparently. And so then having that conversation, oh, but you're so different, you're this, you're that. And it's actually quite hard having a conversation from Australia into all the other countries, because they're the ones with the influence. Like Europe has a huge influence on what's going on in obviously Europe and that part of the world, but then the US has such a huge influence in what's going on in Southeast Asia, and that's where all the consultants come from. So some of us get to flit around in there every now and then, but they're the ones that are making decisions about what happens in there, the big conglomerates of Tyson's and those sorts of things, and the major drug companies are often US based. Yeah.
On the before and after survey forum, did you, in those increases and decreases, agrees and disagrees, did you allow for the change in the population? Of course I did,
Glenn. Of course I did. Yeah, so they were still, so those are the two categories that was, the rest, those are the only categories that were significantly different, and the rest of the categories actually didn't change. So we had 5 categories, of which 3 were complete a waste of time, so we should have just asked if you agreed or disagreed. But they were statistically significant regardless of the decrease in population.
Did you change the minds of any of the vets?
So we anonymised it 100%. So because of that, I couldn't see if we changed the minds of the medicos versus the vets versus the others, unfortunately, because it was supposed to be completely, it was 100% anonymised. So I couldn't track who.
The respondent to say whether they were a vet, medical or
We did, just so that we could see what the population was before and after, but we didn't identify the responses by, because it's completely anonymised. If I'd partially anonymised it, we would have been able to, probably just as well. But we don't know whether we didn't change the minds of the medicos. But the vets think we're just as responsible. So if you're a small animal vet, it's always the food animal vet's fault. So.
Helen,
Yep.
at that panel discussion,
yep.
there were, like you said, there were about 72 people in the audience.
Yep.
I think most of the people in the audience, they were quite educated on the issue.
Yeah, yeah.
And some of the comments that they offered as well sort of indicated that they didn't think that veterinary antimicrobial use was a problem. However, in the community, it might be a very different
absolutely, 100%. Yeah.
And there might be that sense that veterinary, especially agriculture, is a significant issue.
Absolutely.
What do you think of the messages that are percolating?
What do I
Or at
think?
least
What do I think one of the biggest problems that we have in food production is that a lot of perception is driven by the supermarkets. And so because we do 90% in Australia of our purchasing at the supermarket, we are strongly influenced by what the supermarket is telling us about product. Free-range eggs, cage eggs, RSPCA approved products versus non-approved products. And so I think the consumers, by the research that's been done, largely are not that well informed. We have a very well informed small group of people that influence that are influencers in some of the animal activist type groups, and so we know that they're well educated, and they tend to be female. They tend to be more better educated, so postgraduate, and they tend to have a lot of influence with regards to some of the activist groups in terms of what they're demanding, but how well they represent the whole community, I would argue that's probably not that well known. But we know from some of the studies that have been done that change in community, that's why we did the study. There's a nice little study where they did quite an intensive education program to see if we could change people's opinions. So we wanted to know if that would work in an educated group, because we know even in an educated group that people have quite strong opinions one way or the other. So it kind of worked. Yeah. So it's probably worth trying to go a bit broader and try a community group rather than just an educated group.
Yeah.
So,
yeah. There's a question here about the level of antibiotics in animal products.
Okay, so animal antibiotic residues, because we have a national antimicrobial residue scheme where we measure residues, that you can go and look online, you can have a look to see which industries are getting residue levels. It's legally required. We have maximum residue levels that must be complied with, and it's randomly surveyed annually. If you look, most of the residue detections are due to accidental cross-contamination events that might have occurred, say, for example, where feed gets cross-contaminated in the feed milling industry, and you might get an antimicrobial from pig sector going into eggs, but you will see the vast majority of those are negative. And so in terms of compliance to legislation and requirements from MRLs and residue detection and withdrawal periods, that in terms of if you were going to look at that to see if people were doing the wrong thing, then that would indicate that the vast majority of people are doing the right thing. So that's already part of our regulatory framework within which we already operate. So if you were going to use that as an indicator for how well veterinarians were obeying the rules, then it would suggest that veterinarians are very good at obeying the rules in terms of those sorts of things.
It would be interesting to know from a consumer point of view whether they think antibiotics free means this egg has no antibiotics in it versus the chicken that laid it was not exposed to antibiotic free.
Yeah, well, the research that's been done in that space shows that most people have no idea what that means. So antimicrobial free, raised without antibiotics, or any of that type of labelling is largely hugely confused. And the studies that have been done in the UK and Europe show that consumers as a whole don't understand at all what that means. Yeah. Or free range for that matter. But, yeah.
Do you think there's scope for us to be marked in a different position on this and to talk about responsible antibiotics
absolutely.
And not antibiotic-free?
Yep, absolutely.
And that's what we do at humans. We know sick people need antibiotics, and we promote make sure they get the right antibiotics quickly. So maybe we could tilt the conversation, do you think?
I think the most constructive thing that we could do, and which no one else in the world is doing, because we're already in a space where we have low absolute volumes of use. And my argument would be what we don't know is whether the use that we have is appropriate and what the gap is with regards to, is there prevention that's not working? Are there diseases that we're treating that we haven't observed, that we think we're treating, that we're using antibiotics for, that need a vaccine or that need a management change, and the discussion we should be having. We need to stop talking about no use. We need to start talking about appropriate use, and that it's appropriate dose, appropriate route, and appropriate product for treatment. So from an agricultural point of view, we're still talking about reduction. There are small snippets of conversation where they're talking about appropriateness, but certainly from a global perspective, it's all about measuring how much. But we need to be talking about appropriateness by far and away. That's what we should be talking about. Yes, Glenn.
I think one of the difficulties, firstly, is that we live in a world of two-word slogans. I think that's driven by supermarkets, as Helen said. Trying to get a supermarket to sell a message about responsible use or McDonald's is much harder than getting them to sell an absolute message, which is antibiotic-free or free range. So they're really driving the public. They don't get much of the budgets than anyone in this space.
But we need the medicos to help us with that, because we can tell you what we do, but we need the support of the medical fraternity to support that we should be having a conversation about appropriateness, not about absolutes. Because when I ask the question about, well, how much antibiotic do you actually import into Australia for humans in volume, and people are like, why would you want to know that? This is like, well, because that's what you compare us to. Talk about how much antibiotic we buy, not how much we're using appropriately, which is a much more constructive conversation and would be far less challenging for veterinarians when I say, well, how much are you using appropriately? Not how much are you using, because they do not want to have that conversation.
Okay, on that note, we better finish because it's 9:30 and we need some exit the room. Thank you very much for attending, both again in person and online here. Very interesting talk, and I think it's probably an area we need to talk more about in some fashion. Next Journal Club is in a month's time. We'll provide some details around that closer to the time, and thank you very much.